Hi, everyone, and welcome to Wound Care Pro, our weekly series featuring nurse practitioner and wound care specialist and founder of the Wound Care Pro app. We have Anne Walsh with us, and this week we are going to be talking about diabetic ulcers because one person every 20 seconds somewhere in the world is having their limb, amputated due to a diabetic ulcer. And this is something that can be prevented, and this is something that can be treated if caught early on. So, this is a very important episode. We have a series of questions, hopefully, that we're going to dig deep into these diabetic ulcers and help to provide you with some critical information so that you can have a productive discussion with your own healthcare team. And thank you so much for being here.
Thanks for having me.
So very important topic. I would ask just right off the cuff, just what percentage of patients that you deal with are diabetic ulcer patients these days?
These days, I'd probably say about 30%, 40% perhaps.
That's significant. I
Yeah.
mean, it definitely shows a trend. It definitely shows that we have a big problem in this country with diabetes. And I was hearing from the American Diabetes Association, I think about 50% of American adults alone have at least prediabetes or diabetes, and especially the type 2 diabetes, which is reversible and a major complication if you can't get that blood sugar down, diabetic ulcers. So I think, Anne, why don't we start with how would you describe a diabetic ulcer for versus, let's say, a typical wound in an average person?
Well, as opposed to, let's say, a pressure injury, we may see on the back, the sacral area, if the person's, in bed for a prolonged amount of time, whereas a diabetic foot ulcer would be on the foot, typically on the bottom of the foot. So if the person's ambulatory, they're walking and they're putting pressure on the same spot over and over again, and maybe due to neuropathy, they're not feeling that they're pounding on that area. And so when we see a wound on the bottom of the foot, right away we think, is this person diabetic? And you delve deeper into their history. Usually it could be on the toes or, like I said, the bottom of the foot.
So why are they actually considered a diabetic ulcer per se?
Well, typically the foot ulcers we see are on patients with diabetes. And because of their history of maybe uncontrolled blood glucose, they may have neuropathy, meaning they're not feeling where their foot is in space, and they may have structural changes to their foot. And every time they're walking and putting pressure or standing, that area is being pounded on, and you may see callus there, showing that's excess pressure. So that's why it's a diabetic foot ulcer, because typically in diabetic patients. Other patients with neuropathy may develop them as well, but typically it's the diabetic patient.
And so they can be caused by pressure. They just don't feel it. And so it's still considered a diabetic ulcer just because they have diabetes.
Correct. Yeah, the
Okay.
diabetes could be poor circulation, and the neuropathy all sort of together oftentimes leads to these ulcers.
But yeah, that's what I was going to ask you about it. Are diabetic ulcers mainly caused by lack of blood flow, capillary loss versus arterial loss? One or the
Absolutely.
other?
Usually, if the patient has diabetes for a long time and sugars may not be under control, and perhaps they're not doing good foot care, and they may be a smoker, all these things are kind of impacting the blood flow to the area, and just, nerve damage, and it's sort of skyrocketing the risk factors for this person.
So are diabetic ulcers treated differently than a regular wound?
Well, they're treated the same as far as when you're looking at the wound, what am I seeing? How much drainage? Is there necrotic tissue? But they're treated different in the sense that we need to get the pressure off that foot, because that's where they are. And most people are, if they're ambulatory, it's very hard to do that. There's different techniques to try to offload that wound. Otherwise, how can it ever heal, no matter what we're treating it with, if the pressure is continually on the site?
So what is the grading criteria that is used to actually determine what level of diabetic ulcer that a person has? And I'm assuming that depending on the grading criteria, that would translate into different treatment options. And probably something that they could find and clinicians and physicians could find on Wound Care Pro, your app.
Yeah, I mean, there's different grading systems out there. One is the Wagner. So it's just looking at the person's foot, are we seeing, the person's at risk and they don't have an ulcer yet? Are we seeing a callus on an area that we know that the person's putting a lot of pressure, so it's considered a
Mhm.
pre-ulcer? And as things get, progressive, if they do, it could be to the point where it's gangrene. And of course, then depending on what we're seeing, we're going to treat that person differently. Prevention is always key. If we could
Yeah.
prevent it from getting, to worsening stages.
That's why when you have companies like Podimetrics that has a mat that's been given to, at least I think they have a test pilot out there with a couple of VA systems where patients who are diabetic, who are at risk of these diabetic ulcers, can actually stand on this mat once a day, and it'll let them know whether or not a potential ulcer is starting to form underneath the skin, because of course it forms underneath the skin before it breaks open, right?
Absolutely.
There's like
Once you see the
temperature
callus
changes, I
there,
think.
yeah, it's that's great to have a mat like that. You could be ahead of the game. So once you have these wounds, it's very difficult, oftentimes to heal.
And is it difficult oftentimes to heal because of the issue with blood flow? I know we talk about, and I think it's important that, for example, we have someone we work with, and his wife ended up with an amputation due to a diabetic ulcer. And, for her, it was literally, the doctor said it was a capillary issue, it was not arterial. So, for me, it'd be interesting to hear from your perspective the difference there so people understand. Because the first thing I always say is, it's your arteries. You got to get your arteries open, but it's not always the arteries per se that is the problem in getting blood flow to that particular wound.
Yeah, I mean, it could be if the person's sugar is out of control, the blood is almost like syrup. It's so like viscous that those little capillaries oftentimes are damaged from that, from high blood sugar, that in, combination of the poor arterial perfusion. But the sugar alone being out of control certainly sets the stage for these complications.
But it is important that if you do have one of these ulcers, that either your podiatrist, your wound care specialist, your primary care should be sending you for a full vascular evaluation.
Absolutely. That's
So
key.
what that is key.
Yeah.
So once you know that you have this diabetic ulcer, can you go through some of the treatment options? I have a few that I'd love to run by you, and ask you your thoughts. For example, let's say, just that topical oxygen treatment that you can do. What do you think of that for diabetic ulcers?
Yeah, I mean, there's a lot of treatments on the market that you could sort of try first, get a look at the wound. What are we seeing here? Does it need to be debrided? Because that would be important, because no matter what, if you don't debride and there's necrotic tissue there harboring bacteria, it's going to stay in the inflammatory stage and not be able to progress. So that first, if it's a dry wound, you may be looking at hydrogels, that sort of thing. If it's more heavily draining, maybe alginates. And then if you're doing all that and maximizing the person's healing potential, then if things aren't moving, great, trying oxygen therapy or these other therapies. But I, we try the other stuff first. It's more accessible, but certainly it's a great modality to have.
Interesting, you mentioned debridement. We hear that a lot with our patients, and we have some wound care specialists that are successful and other ones that aren't. Why is there so many varying techniques for debridement that lead to very different outcomes? Is
It
there any sort of standard for treatment?
Well, it depends. If you're looking at a wound that has a little bit of necrotic tissue, let's say a little slough, yellow necrotic tissue, maybe you'll think of, the honey products or something like that to debride. If you're talking about more debridement, then, you might need something more aggressive, like sharp debridement at the bedside or surgical debridement, depending on the situation. And people don't realize sometimes by keeping the wound moist, whether you're adding hydrogel if it's dry, or, using an alginate to absorb, but not over dry the wound, the body itself will help debride that wound autolytically, just with
Um,
natural enzymes, so.
What are your thoughts on the hyperbaric oxygen therapy, HBOT? Like, we hear this all the time. We always tell patients, because we've had a few come to us and then have said, it doesn't work for me. It seems to have made it worse. And these are patients that didn't have a vascular evaluation beforehand and had some serious arterial issues and flow issues. So there was no blood flow to even work with. But I'd love for you to talk about, because if done right, I've seen some in miracles with these hyperbaric chambers.
Yeah, absolutely. I think each person has to be assessed to see like what's going on with the wound. Have we maximized, their nutrition? Have we got their blood glucose under control? And try to get all that together and then see if the person's a candidate for hyperbaric. But it's a great treatment to have. But again, if everything else is out of control, so maybe they're not going to get the success if there's no blood getting there, or like I said, the sugar's out of control, or there's infection or something along those lines. But if everything else is sort of put in place, it's a great modality. I've seen it work nice for, people who've had radiation injuries from, breast cancer, let's say, work very nice for that too, or had a mastectomy and have a couple of hyperbaric treatments, helps the healing. So I've seen success with that regard also.
That's interesting
Yeah,
because we've
yeah.
had a few patients that have had radiation injuries to their arteries, and so that might be something they should be discussing with their doctor to see if it's the right option for them.
Could be. Yeah, it's definitely another good tool to have in our box. Yeah.
Just to lay it out for a patient, what would be the indications for a hyperbaric chamber for these patients?
I think a person, depending if they're how severe their neuropathic ulcer is or the diabetic foot ulcer, and they're not responding to other therapies, maybe something like, hey, let's not wait too long. Let's try hyperbaric before things get progressive. And if they're not sort of responding along the path that we'd like to see, once we get all these other things under control.
What are the indications for some of the other therapies like laser, is it E-STIMI?
E-stim. Yeah, a lot of physical
E-STIM?
therapists like the e-stimulation. Yeah. Laser sometimes for scarring it may help with. Again, trying the sort of the more other treatments that are out there that have been working great. And if not, then stepping it up, especially for the diabetic foot ulcer, which is more complicated than in other types of wounds. Certainly, these are great modalities. Sometimes in
When you,
combination with,
I've been hearing a lot about the pulsed acoustic cellular expression therapy, the PACE therapy. I'm curious if you're familiar with that and how it's different than ultrasound.
Yeah, I'm actually not familiar with that. I haven't used it, but it's anything to try to help get that blood flow going and sort of like get those cells stimulated. Because sometimes the cells sort of stagnate and they need something to kind of jumpstart that healing cascade, get those cells get into the area and get things going. So it's definitely I haven't had, like I
We
said, much experience with it, but
know probably because they're not in the traditional medicine um, facilities. I see it a lot of times where chiropractic offices are getting this type of thing and using it to bring in more business. And so suddenly they're not just they're using their being a doctor to adopt all these things and making claims very carefully.
right,
But I think that it sends a wrong message. I have so many patients that come to me, oh, what about this, acoustic, therapy, to improve my wounds and my neuropathy in my feet. And I'm like, I think you're going to get scammed. I think the first thing you need to do is you need to go to the vascular specialist, and I think you need to go get a
absolutely,
vascular evaluation. You need to find a doctor that can make sure you have blood flow clear to your foot, and you need to make sure that you are, again, you've driven this home several times so far in this interview, gotta get your A1C under control. That is so important. And I would love for you to even state it again. Why is it so important to get that glucose under control? What impact does the high glucose have on wound healing? You were mentioning that it makes your blood syrupy, but what does that mean for these
yeah, I mean, it makes
patients?
your blood syrupy, so does the blood flow getting to the area is compromised. It sets a stage for infection when the sugar's out of control. And bacteria love sugar, and things can get out of control as far as that's concerned. So you're setting the stage for infection, God forbid, sepsis, gangrene, all these
Yeah.
things, worsening neuropathy, and then you're putting more pressure on the foot. Yeah, so it's just, and not to mention all the other things, hypertension and problems with your vision and kidney problems and all that goes along with uncontrolled diabetes.
Do you ever use negative pressure wound therapy at
Yeah,
all
we
when you're
don't use
treating
it as much
diabetic
with
ulcers?
with our patients right now on the hospice program, but absolutely, it works fantastic in the right situation. Also to handle the drainage if it's a heavily draining wound, and just to stimulate new growth of tissue, works fantastic.
Can you explain, and I'm using the abbreviations because I cannot pronounce these. I'm not a clinician. Um, MMPs and TIMPs at a level, can you explain them at a level that patients understand and the role they play and ways in which to balance them?
Yeah, well, the MMPs, they're enzymes that are in the wound and they're good. They're needed for the wound healing. But if they get too much, they could actually slow the healing down. So it's sort of a balancing act. So if a wound is heavily draining and we're not managing that drainage, there could be excess amount of them in the wound, these enzymes. And so by us using the right dressing to handle the drainage, if the wound's on the dry end, hydrating the wound, if a wound is stagnating, maybe we could add collagen in there and that'll sort of help, tip the scale and the proteins and what have you to sort of like have good nutrition to help the body sort of regulate so we're not overdoing the amount of enzymes in the wound.
Since you mentioned nutrition, would you talk a little bit because I hadn't realized until we brought Dr. David Alper on board. He's a podiatrist that's with the APMA and also an advisor to the American Diabetes Association. I did not realize the importance of diet. And then you have Abbott that has their Jervy, I think it's called a
Oh,
protein shake.
Juven is one of them.
Juven,
Yes, yes,
yes, for wound healing. And so I started reading that. I did not realize that what you eat actually, aside from your A1C, actually has a big impact on your wound
yeah.
healing. Can you talk about that and also especially the role of protein?
Yeah, absolutely. And we always thought of like vitamin C and zinc and all that, but there's a lot more minerals and vitamins that come into the wound healing and protein, of course, for building new tissue and strengthening the body. So, decrease risk of infection. That's why a lot of these, like with Juven and other supplements, have like
Mhm.
the right amount of all these different ingredients that are needed beyond the vitamin C, the zinc that we all sort of knew about, but it's becoming learned more and more. There's lots of other nutrients that are necessary for wound healing. Very complicated, sort of behind the scenes stuff as the body's rebuilding itself. So yeah, having a good balanced diet and keeping your blood sugar under control certainly is extremely important.
It's really good probably to have your podiatrist or wound care specialist or primary care at that point refer you to a dietitian for specific advice for their situation, I would imagine, for wound healing, based on, balancing that with any other comorbidities that they might have and requirements for their diet.
Absolutely. If they're have kidney problems, their amount of protein might differ from somebody else with.
Yes. Oh, definitely. If you're a chronic kidney disease patient, ESRD patient, make sure you do check with your dietitian because your protein levels are definitely, you're going to need lower intake of protein, and they can definitely dictate how much. Is hydration, a factor in wound healing?
Absolutely. Absolutely.
Oh,
Those cells need fluid to swim across the wound base to try to regenerate. Yeah, you don't want obviously fluid overload if somebody's in heart failure, but you want that balance, and hydration is very important.
so the role of the patient is really big in the healing process. So number one, diet, and what other ways, um, you know, does the patient have to play a role in making sure that their diabetic ulcers are on the mend?
Yeah, I think if they're doing the wound care themselves to really do the wound care that was taught to them and to report any changes to if they're wearing offloading footwear, to adhere to that, or if they're, maybe they're on crutches, depending on the situation to get the pressure off that wound. All of that is going to impact the healing. Keep up with their appointments. They may need regular debridement, or the podiatrist may be shaving a callus around the wound edges, sort of help the heal. So to keep, an active part in their treatment.
Some of the patients have told me they don't want to go to their regularly scheduled appointments because the debridement is so painful. Is it supposed to be painful? Because these patients really don't want to go back. And I always say to them, I said, well, a little pain each week or a big pain in terms of amputation. So you got your choice.
Yeah, I
But
mean, it shouldn't be so painful. Maybe they could put a little lidocaine around the wound edges beforehand to kind of, take the edge off. But if somebody has neuropathy where they're so sensitive, you barely touch the foot and then they feel pain, that's one form of neuropathy versus somebody who has no feeling. So maybe that individual sort of has that. But just talk to their provider and they may be able to pre-medicate them with something, or, let's say Tylenol before the, treatment, or something topical around the wound. Usually the wound edges where the nerves are is where the pain may be.
So one final, thought in terms of this, what are the red flags, that patients need to be aware of in the care of these diabetic foot ulcers or so-called DFUs?
Yeah, I
I
think if
mean,
they see
you go to the doctor, you go to a wound care specialist. I mean, not all are created equal. And
it.
so you really need to be very cautious and be an advocate for yourself.
Absolutely. I think, assessing the wound themselves, are they seeing a change with the drainage, or is the wound getting bigger, or something's, is it bleeding more, or something may be irritating it? These are things that shouldn't be all of a sudden happening. So to reach out to their provider, if they're not getting answers, so, maybe they'll look for somebody else. Um, if there's an odor to the wound or any kind of redness or swelling to the foot, that sort of thing. And maybe if the sugar is going up all of a sudden and they say, hey, I'm not doing anything different with my diet, that could just indicate there's an infection brewing somewhere, that they want to get checked. See what's driving that sugar up all of a sudden.
I actually have another one. I'm that person that's going to say, well, I have one more, just one more, just one more.
Yeah.
Talk about the mental health aspect of preventing and actually healing these DFUs. I mean, it's a process. It can weigh a lot on your mental stability. I mean, and then that impacts compliance. So I'm curious, you ever suggest to your patients, they should actually go see someone, talk to a psychologist about what's happening with them, to help get them mentally on the right track? Or do you feel like you, as the wound care specialist, well, you become kind of the psychiatrist, for
Well, yeah,
them?
sometimes we do, but it's a team approach, definitely. And we're lucky to have great social workers, and some of them are, counselors also, that they'll, counsel the patient and the family and try to. It can be overwhelming if the person feels like they're, this is out of control and they have no control of any of it. So just to have them be an active participant, maybe join some kind of support group, even online if they can't get out there. But definitely, it could be overwhelming. My sister has type 1 diabetes, and I just remember like, oh my God, I can't eat this and I can't do that. It could be stressful, just that you feel like your whole life is, but once you sort of get a handle on it and little by little, I think, try to make those changes, and see that other people are in the same boat as you, I think it sort of helps cope better.
Yeah, and we do have a diabetic foot ulcer group that people can talk to, and if you're on Facebook, and we'll add you to the group. But we allow people to go in there and talk about what they're experiencing. Some they'll
Oh,
post pictures of their wounds. Some patients go in there, and that's how they keep track of their wounds. But also, we suggest going to CarePix and downloading that app and being able to take pictures of their wound every single day, and it makes it really easy for them, that if they do see changes, that they have a place that they're tracking these pictures in a HIPAA compliant way, and they're able to email them to their
oh,
doctor in a HIPAA compliant way. So
that's great.
um yeah, so that's kind of interesting. I think that would help. Is there anything else I'm missing in terms of diabetic ulcers that we didn't cover that you want to cover in this session?
I think it's about it. I think just prevention for those patients who don't have a diabetic foot ulcer, to
Yeah.
really do daily foot care, something as simple as clean their feet daily, in between the toes, keep their feet moist, lotion it, but not between the toes, keep that dry. And if they see anything, callus forming, don't self-treat, maybe get to a podiatrist. Sometimes some things as simple as that. Don't walk barefoot, on the beach, the sand, the hot, anything could cause problems with your foot. And good footwear that, goes a long way to prevent, so if you have a diabetic foot ulcer on one foot, you want to make sure you're taking care of the other foot.
Yeah, and one of the things, there are a lot of people that don't have, a lot of mobility, and so we tell them to get in front of a mirror and just look at your foot through the mirror. Anytime someone comes to visit you, if you live alone, make sure just to have them check for any changes. Anyone that comes over, just have them just take a quick glance at your foot and see if anything's going on. It's really important, and your life can depend on it, because the one patient that is very close with us just recently that got an amputation, she didn't have arterial problems, but she went septic pretty quickly.
Wow.
And so she just didn't see it coming. She didn't know. She had
Mhm.
the neuropathy where she didn't feel anything. And so she didn't even see it coming.
Wow.
We've also had another person that has actually a genetic neuropathy. and he was very active, and he was so tired of just getting these ulcers that when he just because as much as he would try, he just could not keep up with what was developing on his feet.
Mm.
And so much can develop when you don't have the feeling. And so he ended up with becoming a bilateral amputee because he just could not deal with it anymore. And he was just in the hospital a lot. So important, really got to pay attention to your feet. And Marcia is coming in. I can't pronounce MMP, what it stands for.
Oh, it's matrix metalloproteinases, the tongue twister.
Yeah.
I could probably type it in
So
there.
yeah, it's just was a mouthful. I can't pronounce it, but thank you so much for joining us. If people want
Oh,
to
of
check
course.
out your app, I'm trying to get her a website, Wound Care Pro dot app. Let's see if it actually works here. Maybe it'll work by now, maybe it won't. But what I'm hoping is that we can get that to work for you, and then everyone can just go to Wound Care Pro dot app. But right now, until that is up and running, what is your website?
So well, on the App Store and the Google Play Store, it's Wound Care Pro. But if you go on the
Right.
site, the actual website is palliativewoundcarepro.com.
Perfect. And hopefully we're crossing our fingers by next week. Let's hope. So before we go, what should we cover next week? Any topic that would be timely that we can dive into in our next session of Wound Care Pro?
Yeah, I mean, I don't know if anyone's interested in pressure injuries or pressure injury prevention. If that's anything, that's might be something if anyone's caring for a loved one at home or they themselves, you know.
I think that would be huge because that is a really big issue that we deal with so many of our patients that end up
Absolutely.
sedentary, especially ones that with who are recent amputees. We just had a patient that was in the hospital for 5 days, and she ended up with a pressure injury just to lever above her buttocks.
Oh yeah.
So it's really important. And Marcia, I mean, who's in our live studio audience, was saying she's very active and she had one. So
Yeah.
I think it'll be a very popular topic, and I think we'll dive into that next week.
Sounds great.
So, with that, Anne, thank you so much for donating your time every week and helping to educate our audience on so many important topics. And hopefully, we'll get our Wound Care Pro app up and running for you. But again, people can go to the App Store or Google Play and download it. It's designed for clinicians and physicians to guide them through the process of caring for different types of wounds. But patients can go on, and I think it's $4.99. You can download it and get some really great education, very well presented from Wound Care Pro. But thank you so much, Anne. We really appreciate you, and we will see everyone next week.
Great. Thanks, everybody. Have a great evening.